Hello, everyone. Welcome to Concord Biotech's webinar on the role of daptomycin in severe endocarditis. Infective endocarditis is an infection of the inner lining of the heart's chambers and valves. It can cause irreversible damage to the heart, and if not treated quickly, it can become life-threatening. Therefore, the right treatment under specialized doctors is crucial in such cases. Today, we have with us Dr. Jyotishka Pal, who is a consultant at NHRTIICS, that's Rabindranath Tagore International Institute of Cardiac Sciences, Kolkata. He brings with him years of experience and excellence in critical care practice. He is also a keen researcher and has published articles in well-known journals. Dr. Pal, welcome, and we are very immensely privileged to have you on this webinar, sir. And we look forward to sharing your learnings.
Thank you very much for the kind introduction. Today we'll be talking about the role of daptomycin in severe infective endocarditis. Now, infective endocarditis is one of the intriguing infectious disease etiologies entities that we come across in our practice. Infective endocarditis has got a varied presentation, starting from a very severe acute one to an indolent one. The organisms are cutting across board from the gram positive to the gram negative to the Hackett organisms, as we know, to fungi and so on and so forth, to even Coxiella, which are very difficult to be cultured. The difficulty in infective endocarditis also stems from the fact that the treatment course is often quite prolonged. The complications, when they occur, are varied and severe quite often. And so it poses a challenge to all of the physicians who are treating or who have to treat infective endocarditis. We having practiced in cardiac centers, often quite often come across in our clinical practice these entities, and we face a lot of difficulty sometimes in finally getting to treat these sort of patients. Now, since we are going to talk about daptomycin, we will be restricting our talk to daptomycin. As we know, is a drug which is useful as an antibiotic in gram-positive infections, and so we'll be restricting our talk to the gram-positive infections, the agents that cause infective endocarditis, and thereby the role of daptomycin in treatment of such scenarios. So, gram-positive organisms, they are an emerging problem. In this part of the world, we usually come across gram negatives.
Recording in progress.
And but in such scenarios of infective endocarditis, gram positives are the most common thing of the organism that we come across. Gram positive organisms range from the organisms which colonize the skin, for example, the coagulase negative staphylococci, the Staphylococcus aureus, bacillus, and the cornybacterium. The oral or gastrointestinal pathogens like the viridans group of streptococci and the enterococcus species, and the organisms which are often associated with impaired cell-mediated immunity like Listeria and Rhodococcus. Now, infective endocarditis, primarily caused by gram-positive bacteria, is associated with a high rate of morbidity and mortality, which represents a large burden to the healthcare system. Although infective endocarditis is associated with a variety of microorganisms, Staphylococci, Streptococci, and Enterococci account for the majority of cases. And Staph aureus, amongst all of them, is the most commonly detected positive organism. Now, methicillin-resistant Staph aureus has emerged as a common pathogen in both healthcare and community-acquired infections. And community-acquired MRSA has been found to be particularly responsible for causing infective endocarditis in patients who have a compromised immunity, for example, example, in HIV and AIDS scenario. MRSA infections, including infective endocarditis, are associated with a higher level of mortality compared to methicillin susceptible Staph aureus strains. The dilemma is that the resistance of pathogens to commonly used antibiotics is one of the major public health problems, and the successful treatment of infective endocarditis thereby remains challenging. Patients with infective endocarditis require an aggressive treatment approach with effective antibiotics or a combination of effective antibiotics and surgery. Now, the therapeutic options for the usual gram-positive infections, which they comprise of ampicillin, ceftriaxone, the aminoglycosides. But for the resistant gram-positive organisms, we have in our armamentarium the following agents, which are mainly vancomycin, teicoplanin, linezolid, tigecycline, and last but not the least, daptomycin. The vancomycin, as we all know, is a glycopeptide. It's indicated in potentially life-threatening gram-positive infections. It's moderately bactericidal in nature. Teicoplanin is also belonging to the same group of antibiotics, and it's also bactericidal in its nature. Linezolid is an oxazolidinone. It is indicated for complicated skin and soft tissue infections and for community-acquired pneumonias and so on and so forth. But the mechanism of action is primarily bactericidal. Tigecycline is a novel group of antibiotic. It mainly belongs to the class like glycine. It's affiliated to the tetracycline minocycline, but the structure is different. It is effective for both gram-positive and gram-negative infections, and particularly its use as an antimicrobial is for the complicated intra-abdominal infections and skin and soft tissue infections. Its mechanism remains bactericidal. Now, daptomycin is a novel class of antibiotic belonging to the cyclic lipopeptide group of antibiotics, and is primarily used or indicated for complicated skin and soft tissue infections and bacterial endocarditis, particularly the right-sided infective endocarditis. Its spectrum is purely for gram-positive organisms, and it's highly bactericidal. Now, of all these agents, the therapy for MRSA infective endocarditis is basically vancomycin, teicoplanin, and daptomycin, often in combination with other drugs so as to have a synergistic effect and so as to achieve a rapid bactericidal effect and a rapid kill of the bacteria that you are dealing with, so that life-threatening consequences or sequences of infective endocarditis are managed at quite early stage. The evolution of drug resistance for Staph aureus, as we know, initially penicillin was the drug of choice. Now, since 1950s, penicillin-resistant Staph aureus started coming into the forefront. Now, from 1960s, MRSA evolved. We found that they were now not sensitive to the usual antibiotics. Having introduced vancomycin and methicillin in 1958-59, subsequently, by the use or the greater use or the wider use of vancomycin, we saw that by 1996, there were evidence of heterogeneous vancomycin intermediate Staph aureus, and subsequently later on, after around maybe 5-6 years, there came the evidence that there were in community, not in community only, but in a clinical practice, the emergence of vancomycin-resistant Staph aureus. So, hence, the importance of daptomycin in the clinical context of treatment of infective endocarditis, where we now come across quite a few numbers of methicillin-resistant Staph aureus. Now, coming to daptomycin. Daptomycin, as we discussed, is a newer class of antibiotic belonging to cyclic lipopeptide. It has a novel mode of action. We'll come across later. No cross resistance with other classes have been noted yet. The mechanism of resistance, it's not right to say that there are no known mechanism. There are mechanisms of resistance, particularly for Enterococcus species, Staphylococcus. But the mechanism of resistance is, unique and much less evidence as compared to the multiple resistant mechanism that we come across in gram-negative organisms. There is a broad spectrum of activity against gram-positive bacteria, including MRSA. It is rapidly bactericidal, which is a very good thing or a good property for this drug. It's 90% bound to plasma proteins, has a less volume of distribution, and it has got no cytochrome 450 interactions, whereby the drug-drug interaction or side effects are minimized, and it is used or can be given in a once daily intravenous infusion, and that too can be given as a bolus infusion even, so as to have the maximum efficacy as well as ease of administration to a patient. As we're talking, the mechanism of action is a novel one. Daptomycin, what happens is in the presence of a divalent cation, for example calcium, it attaches to the cell membrane, and thereby after attachment with the cell membrane, the lipophilic end of the daptomycin molecule, it causes a pore formation of the cell membrane, whereby there is a sort of lysis of the cell membrane, which ultimately leads to the bactericidal effect of the antibiotic. In association with that, whereby the cell membrane is disrupted, it has also effect on the DNA and RNA, whereby those multiplications and replications are suppressed. The good thing about daptomycin is that it's not only effective for cells which are in the active growth phase, it can also have its effect in cells which are in the quiescent stage or the resting phase. So that's another good effect of daptomycin. Now the approved indications are that it is indicated for the treatment of complicated skin and soft tissue infections caused by susceptible strains of gram-positive bacteria, as well as for the treatment of Staph aureus bacteremia and right-sided infective endocarditis. It has also received approval for the treatment of right-sided infective endocarditis due to Staph aureus and subacute bacterial endocarditis when associated with right-sided infective endocarditis in Europe, though it's not indicated for the treatment of pneumonia because it gets ineffective in the presence of the surfactant of the lungs. Now, it has a predictable pharmacokinetics. It has, after the initial dose, it has got a long half-life, so which is suitable for a once daily dosing. It has got no need for therapeutic drug monitoring. Renal excretion is almost 70% of the dose, and no active metabolites are there in the plasma. It has got also a post-antibiotic effect, which makes it suitable for the intended use. The pharmacokinetic property which most likely determines its efficacy is the area under the curve under the MIC. That ratio is the most common thing which determines its efficacy. Now, the bactericidal activity of antibiotic agents in vitro, if we compare the linezolid, vancomycin, and daptomycin, as we see, post-administration of these three antibiotics, if we see the colony formation unit, there is a decremental, the fast decremental effect of daptomycin is quite evident, as has been depicted in this red graph. So IDSA guidelines in 2011, it recommended that daptomycin be used for hospitalized patients with complicated skin and soft tissue infections and for adults with uncomplicated bacteremia and native valve infective endocarditis and for management of MRSA-related bone and joint infections. So now the guidelines, even up to the European Society of Cardiology guidelines for infective endocarditis, they have incorporated uh, the daptomycin to be used not only for staph infections but also for complicated MRSA, as well as for vancomycin resistant enterococci, even for right-sided as well as left-sided infections. Efficacy for daptomycin for the infective endocarditis, as we see, more or less for uncomplicated bacteremia, for complicated bacteremia, as well as right-sided infective endocarditis, it is quite good, as has been depicted in the success rates at 6 weeks. For left-sided infective endocarditis, though it's less efficacious, but in such scenarios whereby we find that the organisms are resistant to the usual antibiotics, we are left with no choice but to administer daptomycin. Bactericidal activity of vancomycin and daptomycin. The daptomycin obviously is having a better bactericidal activity. As far as the dosage in infective endocarditis is concerned, for adults, the usual advocated dose was 6 milligram per kg per dose IV every 24 hours for 2 to 6 weeks for right-sided staph aureus endocarditis. But the guidelines have upgraded it to around 8 to 10 mg per kg per dose IV every 12 hours, and even up to 10 to 12 milligram per kg per dose for multi-drug resistant enterococcal endocarditis as part of combination therapy, as I was talking about initially, with different classes of antibiotics, starting from aminoglycosides to tigecycline to even phosphomycin. So daptomycin is also an alternate option in patients with methicillin sensitive staphylococcal associated infections, left-sided endocarditis, as I was talking about, to treat native valve staph aureus endocarditis for 6 weeks and multi-drug resistant enterococcal endocarditis for more than 6 weeks, even up to 8 weeks. Studies have demonstrated the safety of doses of at least 8 milligram per kg per dose IV for 24 hours. Limited safety data are available for use beyond 28 days, though the complications that we come across are, limited. They are not, very common. Rather, I would say that they are uncommon. This is the dosage for the children and adolescents. They recommend 6 milligram per kg per dose for 6 weeks for children and adolescents for 7 to 17 years, and below that, the higher dose is recommended because of the volume of distribution related issues. Results from the European Qpcin outcomes registry and experience, it gives a gross idea for right-sided infective endocarditis. It's a very good drug, and overall it has got an efficacy of almost 80%. The vancomycin versus daptomycin, as far as the MIC are concerned, there has been a slight decrease of daptomycin intrinsic activity, but not in the bactericidal activity in the vancomycin intermediate staph aureus isolates. Still now, there has been the MIC, there's a lower MIC increase of daptomycin than vancomycin. The decrease of vancomycin bactericidal activity is 70% for heterogeneous visa and 100% for the visa strains. Maintenance of daptomycin bactericidal activity has been found in all vancomycin intermediate strains of staph aureus, and it is also bactericidal against VRSA. The vancomycin creep is the MIC creep for vancomycin is a known phenomenon. So of late, the MICs have been, the downgrade to sensitivity for the vancomycin has been now put at 1, 2, and 4 for sensitive, intermediate, and resistance. And for the same, the daptomycin is still effective as a alternative to these to treatment of these organisms in such complicated scenarios. As the comparison of the standard agents for Staph aureus bacteremia and endocarditis, as has been depicted in this forest plot, as came out in New England Journal of Medicine way back in 2006. Daptomycin had been found to be better than standard therapy, and the complications or adverse effects and all-cause mortality also favors the use of daptomycin. So in conclusion, infective endocarditis, primarily caused by gram-positive bacteria, is associated with a high rate of morbidity and mortality and represents a large burden on the healthcare system. The successful treatment of endocarditis remains challenging because of resistance of pathogens to commonly used, as the resistance to pathogens to antimicrobials which are commonly used is increasing. Daptomycin, on the other hand, is bactericidal and is associated with a concentration-dependent activity and has been found to be quite effective and efficacious in treatment of such scenarios and organisms. Thank you.
Thank you, Doctor. That was quite illuminating. At this point, I would like to have any questions. If there are any questions, please do unmute yourself, viewers, or from the Facebook Live, if you can ask your questions in the chat window. I think we can take those questions. Okay. I think, Doctor, there aren't too many questions at this point in time, but in case there are in the future on the Facebook page, etc., we will certainly reach out and have them clarified through you, and
Sure.
definitely we'll have them put up on the page as well. Thank you very much, Doctor. Really grateful for sparing your time. Thank you so much.
Thank you.
Thank you, sir.